Hi, my name is Ahmed Mustafa. I am cardiology lecturer at Ain Shams University. Today I'll be guiding you on a very important topic in the cardiovascular system, which is the systemic hypertension. It's a very common disease with a high morbidity and mortality. So, what do we call a high blood pressure? A patient is called to have hypertension if his blood pressure systolic is persistently higher than 140 or his diastolic is higher than 90. It doesn't need both to be there, just one of them. If you have a systolic higher than 140 or a diastolic higher than 90, this patient is having high blood pressure, or what we call hypertension. Most of cases of hypertension, of arterial hypertension or systemic hypertension, we call essential, which is primary or idiopathic. It's a primary or an idiopathic disease with multiple factors affecting it. Genetic predisposition and environmental factors and the lifestyle of the patient, all of this is affecting his tendency to have high blood pressure or hypertension. So you need to know that many patients who have hypertension, especially the essential hypertension, they don't have symptoms. And like I told you before, it has many things to do with the environmental and the individual factors, including the advanced age, because the arteries get more stiff with age. That's why you get a higher population of high blood pressure or hypertension in the older patients. It's also related to obesity, because this increased weight and the physical inactivity related to it raises the blood pressure. Other environmental factors are important, and the most important one is the high salt intake, the sodium intake, because sodium is the electrolyte that regulates the blood pressure, and a high sodium intake is closely related to high blood pressure. What about other causes? The secondary hypertension only comprises just 10%, just 1/10 of your patients presenting with high blood pressure will have secondary hypertension. And we can summarize most of the causes of the secondary hypertension in two systems, the renal system and the endocrine system. The renal system, the patients could be having chronic kidney disease. If he is having renal dysfunction, it is in itself can raise the blood pressure. The other disease which is not uncommon is the renal artery stenosis, because if the renal artery is stenotic, you will have a kidney that is hypoxic, and a hypoxic kidney releases more renin than a normal kidney, and this renin in turn will activate the angiotensin system, and you will get high blood pressure. What else? The endocrine system, mainly the suprarenal gland. Any excess hormone in the suprarenal gland can cause high blood pressure. If you have excess aldosterone, which increases the sodium in the blood, it's called Crohn's disease. If you have an excess of corticosteroids secreted from the suprarenal, it's called Cushing, and it also causes high blood pressure or hypertension. What about the drugs? The medications, the anti-inflammatory medications, either steroids or non-steroidal anti-inflammatory drugs, the painkillers, most of them cause high blood pressure because most of them cause salt and water retention, and as well as the oral contraceptive pills in females. About the substance of abuse, the most important one that causes high blood pressure is cocaine, because it is a sympathomimetic. It increases the activity of the sympathetic nervous system, and this is how it raises the blood pressure. Another hormone that is secreted from the suprarenal gland is the adrenaline and the noradrenaline. And excess of both is in a disease that is called pheochromocytoma. It is an increase in the activity of the suprarenal medulla, and this patient also gets high blood pressure. So after identifying the causes of the high blood pressure, we need to know that to diagnose hypertension properly, you need to have a good technique. So how do I prepare my patient for the measurement of the blood pressure? First, you don't get the patient rushing into the clinic and you measure the blood pressure immediately. You need to give him a rest of 3 to 5 minutes out of any physical activity. He needs to be free of smoking for at least 30 minutes. And the room should be quiet with no noise. He should have his back and his arm, the arm which you are measuring, they should be supported, and the patient should not be talking in between or during the measurement. You need the cuff to be at the level of the heart, and the cuff size should be 75 to 100% of his arm circumference. So in a patient that is overweight, you should use a bigger cuff, and if he is thin, you can use a smaller cuff. And for the automated devices, there is a list of cuffs that there is a chart for the size. If the it tells you if the size of the arm is like 30 centimeter, you can use a cuff which is around 25 centimeter, and so there is a sizing chart in the automated device. But for the manual device, you can use this thumbs rule. The cuff should be 75 to 100% of the arm circumference. So how many measurements should I take? I should take at least 3 measurements, and I take the average of the last 2. What if they are discrepant? What if I have a very high reading and the other one is low or normal? I take a 4th reading. I take a 4th reading and average the last 2 readings. So how and when do I diagnose hypertension? I diagnose hypertension if I get the patient in 2 successive visits to my outpatient clinic, and in both visits I get that the average of the 2 readings that I talked about earlier is high. And a single visit is not enough to diagnose high blood pressure, except if it is too high, except if it is grade 3 or above. So what about other ways? Do I have other ways to confirm high blood pressure? Yes. You can. There is a device that is attached to the patient's arm, and it measures the blood pressure every 30 or 15 or 16 minutes. The patient is doing his activities, his regular activities, with the device on his arm, and after 24 hours he gets back to the OPC with the device to you, and you analyze the average of all of those readings during day and night. This device is called the ambulatory blood pressure monitor. Another way is to get an automated device for the patient at home and let him measure the blood pressure at day and night for more than 1 day and gets you his readings. And those 2 ways are very important because they can confirm the high blood pressure without the need for repeated visits. In addition, they can relieve the tension of the patient being in the clinic measuring the blood pressure, because sometimes some patients they get nervous when you are measuring their blood pressure. So what we call the white coat effect, and that's why you get rid of, when you are not there at home or with the ambulatory device, the measurements are more near to the reality. So what's the most common clinical presentation of high blood pressure? The most common clinical presentation, like I told you before, is no symptoms. So this patient mainly is discovered accidentally. For example, he is coming to have an elective surgery, and we discovered that we measured his blood pressure and found it to be high. He's coming for a routine evaluation, and we found his blood pressure to be high, because most of those patients are, like we told before, is asymptomatic. Sometimes he may present with headache or epistaxis, and in the worst of ways, the worst of times, the patient can present with the end organ damage as his first presentation. He comes to you with pulmonary edema, he comes to you presents with stroke, he presents with intracranial hemorrhage as his first presentation. And this is a very critical part in the treatment of the patient, because the patient may ask you, "Doctor, why am I receiving medications for this high blood pressure? I'm feeling well, I have no symptoms. Why are you giving me medications? Why are you giving me those drugs?" You are giving the patient drugs because not just you don't want to relieve symptoms, you are not guided by the symptoms. You want to prevent the blood pressure from damaging his vital organs. You want to protect his vital organs from the damage caused by this persistently high blood pressure. What kind of damage the patient may get? You can memorize this in mnemonic. You get the brain, the heart, the kidney, and the eye. The brain, the blood vessels can be leaky, they can rupture and cause the patient intracranial hemorrhage, or the reverse. The blood supply to the brain could get less with high blood pressure, and you get what we call a stroke. or a mini stroke, which we call a TIA, or a transient ischemic attack, which is transient interruption of the blood supply to a part of the brain. The difference between the stroke and the TIA, the stroke is permanent, it leaves permanent damage. The TIA is very transient, or a temporary weakness, temporary deficit. Okay. Regarding the heart, first the heart try to remodel itself in response to this high blood pressure by getting more thicker. It gets a thicker left ventricle, what we call left ventricular hypertrophy. And after a period of the hypertrophy and the remodeling, this fails to accommodate this high blood pressure, to adapt to this high blood pressure, and this is how the patient gets heart failure. Another organ that gets damaged is the kidney. This high blood pressure damages the blood vessels of the kidney, what we call the glomeruli. And when the blood pressure damages those glomeruli, which are the functioning units of the kidney, the patient gets renal dysfunction and renal failure. Another organ, which is the retina. The retina is the posterior layer in the eye responsible for converting the light and the colors into neurologic or electric signals. Sometimes this blood pressure causes the blood vessels in the retina to be leaky, and this patient will get hemorrhage in this layer. Or, like in the brain, this blood vessels gets to be stenotic or narrowed, and this patient gets retinal ischemia, which is less blood supply to this layer, causing the patient a drop of vision. And this is a demonstration of what I told you. And those are the categories of the blood pressure from grade 1 to grade 3, and the normal and the high normal. Note that the patient with the high normal blood pressure is not yet receiving medical treatment, but I can tell him to take some steps which are called the lifestyle modification to prevent him from progressing to be a hypertensive patient. I can warn him, you can do that, I can advise, you can counsel him about some lifestyle modifications which will get him his blood pressure back to normal instead of progressing to frank hypertension. And this is the important question I told you before. We need to treat the hypertension not for the sake of symptoms, but to reduce the adverse events I told you before. So what are the targets of the blood pressure? Generally speaking, we need the blood pressure to be lower than 140/90. In a younger patient, and by younger I mean younger than 65 years, we need to lower the blood pressure below more than 140/90. In older patient older than 65, we need just to be below 140/90, because those patients tend to get dizzy. They tend to get postural hypotension if we aggressively treat their blood pressure. So if you have a young patient, and by young I mean below 65, you get to a lower target. If he is more than 65, just below 140/90. So how do we lower the blood pressure? Is the pills enough? The pills are not enough usually to lower blood pressure. We need another thing. We need the lifestyle modifications. And those lifestyle modifications are all about reversing the lifestyle that is leading to or making the blood pressure high. Like what? First, this patient needs to lower his sodium intake, less than 1500 milligrams per day of sodium. And how does this translate? This translates to a 5 gram of table salt maximum per day. There is a good diet that is a fresh diet called the DASH diet. It is a diet meant to control the blood pressure, and this diet tends to shift the patient from processed food and dairy products which are rich in salt to fresh vegetables, fresh fruits and whole grains, and nuts which are low in trans fats and saturated fats, and also low in sodium, which more the processed meat and the dairy products are rich in sodium. The patient needs to stop smoking. He needs to stop his alcohol consumption and do some aerobic exercise. The most easy one is the walking. He can do walking for at least brisk walking for 15 minutes a day. And one of the most important is to get some weight loss, because if the patient is obese, his blood pressure will be very difficult to control. But if the weight is lowered, this has a direct effect on his blood pressure. It makes the blood pressure control much easier. The blood pressure may even revert to normal. So, and this is what I talked about the salt intake. What about the pharmacological lines of treatment? I have the main first line is the angiotensin converting enzyme inhibitors and their cousins, the angiotensin receptor blockers, and the calcium channel blockers, and the thiazide. Usually, the thiazide diuretics are not used alone. They are either combined with ACE inhibitors, ARBs, or calcium channel blockers. I may even combine the three of them. And there are many drugs in the market who have two of them, or even three of them in a single pill. We call single pill combination. The other medications we call a second line, like the beta blockers, alpha blockers, and other diuretics. What about specific group of patients? We have specific group of patients with hypertension in which we don't resort to this arrangement of the blood pressure medications. Let's give an example. If you have a patient with ischemic heart disease, a patient with angina, you need to reduce the anginal symptoms. What medication of the aforementioned that can lower those? The beta blockers, of course. The beta blockers will decrease his anginal episodes. So in this patient, if he's having high blood pressure or hypertension, I'll be using the beta blockers not only to lower the anginal episode frequency, but also to control his blood pressure. In a pregnant woman, we need drugs that doesn't cause fetopathy or fetal abnormalities. And the safest drugs to our knowledge is the alpha-methyl dopa and hydralazine, for example. What about hypertensive crises? We have two types of hypertensive crises, which are the urgency and the emergency. And actually, they are two different entities of patients that need different management. The patient with the hypertensive emergency is having high blood pressure, but in addition, he is having acute target organ damage, like presenting with stroke, presenting with acute pulmonary edema, presenting with intracranial hemorrhage. This patient needs to be admitted to the intensive care unit, and his blood pressure will need to be lowered within 1 to 3 hours according to the condition. However, in patient with a hypertensive urgency, he is having high blood pressure, but he doesn't have any end organ damage. He doesn't maybe have no symptoms or even just headache. So he doesn't have end organ damage. You don't need to admit this patient. You do not need to promptly reduce his blood pressure, give him like captopril, IV diuretics. You don't need to give him all of this. Just give him proper oral medications and discharge this patient on a plan of follow-up, because he doesn't need to lower the blood pressure suddenly. What are the presentation of the hypertensive emergency? You don't need to memorize just the 4 organs I spoke to you about before. For example, the kidney, the patient can present with acute renal failure. The heart, the patient can present with myocardial infarction, can present with acute heart failure in the form of pulmonary edema. About the retinopathy, the patient will present you with acute blurring of vision, which could be due to either retinal hemorrhage, because of the vessels becoming leaky because of the high blood pressure, or the vessels becoming narrowed, or this vessels becoming leaky causing edema into the retina, which we call the papillary edema. And it can present with neurologic manifestations, like we told you, the stroke, the TIA can come with intracranial hemorrhage, and he might come with brain edema, and this brain edema will cause the patient to lose his normal consciousness level, what we call hypertensive encephalopathy. And it's of note and to be remembered that the patient with neurological manifestations don't rush to lower his blood pressure suddenly. You should lower his blood pressure gradually and not completely in the first 1 or 3 hours. Why? This patient is depending on this high blood pressure to deliver good blood supply to the brain. This pressure 200 to 130 will deliver good blood supply to the brain, because most of the blood vessels of the brain at this particular time are vasoconstricted. So you need this blood pressure high to overcome the resistance in the cerebral blood vessels or in the brain blood vessels. If you get to lower this very rapidly, you will lower the blood supply to the brain. So if this patient, for example, is having a small stroke and you lower the blood pressure very rapidly, the blood will not get good to the brain in a good manner, and it will be lower. The blood supply to the brain will be lowered, and you will get a bigger stroke. So you enlarge the size of the stroke by this rapid aggressive management. Okay, what about the other patient with the hypertensive urgency? The patient with a hypertensive urgency is having a high blood pressure, but no target organ damage and maybe no symptoms, just headache. And this patient, don't rush to lower his blood pressure. It's enough to prescribe him a proper dosing of oral medications and get him to follow up with in the OPC to measure his blood pressure in another time after 4 days, 5 days, or a week, to be sure that his blood pressure is getting lowered and it is under control. There's no need to give him nifedipine, no need to give him diuretics, because those may lower the blood supply to his vital organs, like the patient we spoke before, the patient who is having brain abnormalities or neurological damage. The same here, if you get to lower his blood pressure very rapidly, you could turn this urgency into an emergency, because you lower the blood supply to the brain and he may get a stroke, he may get hemorrhage. So please, if you get a patient like this in an urgency, just give him oral medications, reassure him and send him home with an outpatient appointment. That's all, thank you. The rest of the slides just is an enrichment material about how to lower the blood pressure and how to modify the lifestyle of the patient. Thank you.